This podcast does not provide medical advice. Please listen to the complete disclosure at the end of the recording.
Hello and welcome to Everyone Dies, the Flight of Ideas episode. I'm Marian Matzo, and today we'll be chatting with Dr. Mary Kazanowski, a nurse practitioner with 30 years experience as a hospice nurse. We appreciate those of you who subscribe to our podcast, and you can leave support for our show by rating us, giving 1 to 5 stars, and leaving a review. We are a not-for-profit organization. We would love your help in distributing our work. Remember to check us out on Facebook, Twitter, and wherever you get your social media connections. So we've been doing a series on what you can learn from people who are dying from the book, The 5 Invitations by Frank Ostaseski. Having worked in hospice, I've known many people at the end of their lives. I've often heard them talk about the things that they'd wish they'd known before the last days or weeks of their lives. But we really don't have to be dying ourselves to learn these things, but we could listen to the people who have been facing their own deaths. Our guest today is Dr. Mary Kazanowski, a nurse practitioner with a doctorate in nursing, a former professor at St. Anselm College in Manchester, New Hampshire, and someone who has worked for 30 years as a hospice nurse in New Hampshire and is still working 3 days a week. So welcome, Mary. How are you?
I'm great. Thanks for having me.
Thanks for taking time out of your day to talk with us. The book I was referring to, The 5 Invitations, the 5 invitations are, number 1, don't wait. 2, welcome everything and push nothing away. 3, bring your whole self to the experience. 4, find a place of rest in the middle of things. And 5, cultivate a don't know mind. Now, when I first learned about hospice, I learned it from you. God, that was, 25 years ago or so. And I was a Soros Scholar for the Project on Death in America. And part of that work was learning about hospice. And so I would go out in the car with Mary, and she talks fast, she moves fast. I'd always laugh at her. She'd take her inhaler and the whole car would be filled with the inhaler stuff because she couldn't stop talking long enough to take her breath of her inhaler. Yeah. So it was.
I'm not supposed to talk. I'm supposed to listen. I have learned that with hospice. I'm supposed to listen.
But she was a fantastic teacher, and I eventually started working per diem for hospice. And we were 2 nurse practitioners because back in that day, remember, Mary, they wouldn't hire us as nurse practitioners. They didn't have jobs for nurse practitioners. We were registered nurses, but they were getting a pretty good deal because they were getting our nurse practitioner experience for the price. And so it was a great way to learn. So I'm curious, though, I don't know that I've ever asked you, whatever made you decide to be a hospice nurse?
Well, I always enjoyed working with seriously ill people. My background was ICU nursing. I saw a lot of suffering there, a lot of people that were near death, but were still fighting until the end. And then I enjoyed oncology working. I worked oncology my summers for 3-4 years while I was teaching. So I had often taken care of people near death, but in different settings, usually in the hospital setting. So when it just became apparent, another summer was coming up. I was teaching, and I used to look for a job every summer. There was a hospice opening, and I thought, this is exactly what I want to learn about. And I thought hospice would be the same as caring for people in the ICU or in the hospital. So I got the job. First, I didn't get the job. They told me I wasn't qualified.
Really?
Yeah. They told me I wasn't qualified, and they put an ad in the paper. They were still looking for someone who was qualified. And then I got a call back. I got it. And
wait. So what qualifications were
they
they
looking
looking
for?
for that you didn't have?
Don't know. I never asked that question. It was not a nurse that interviewed me.
Ah,
I think that may have had something to do with it. She asked me what I thought was important to take care for somebody at end of life, and I think my answers were what you do in the hospital. Focus on someone's pain in those days. I'm sure you remember, Marianne. We were very hesitant to give too much pain medicine.
mhm,
You didn't want to sedate someone, and physicians had that burden too. I'll call it a burden or a challenge. And so we as the nurses had to advocate at the bedside and call them, and they're still in pain. And so I sort of talked all that up as I had a lot of experience in being an advocate in those ways. And I don't know, she just didn't particularly value what I had to offer. So I don't know. So I did within a week. I got hired. So
mhm,
thank God, because it is different. I was so pleased, and what was so different and striking was hospice brought me into the home of the patient, and I was no longer the person telling them what to do. Really, it was their home. It was all about them. I was the learner. I learned from them. Yeah. Did I have some information to share with them, medication management, etc.? Yeah. But to me, I was just, oh, I am a guest in their home. And that's the way it should be.
mhm.
So I learned a lot from them. And it showed me how, and maybe she saw that I didn't recognize that how hospice was different. I didn't get tired the first time, but I was so glad. Because I've learned so much from families and patients.
So can you tell me like three things you've learned about what it is to be looking death right in the face?
You know, that piece, I don't have the answer to. What I have, because I find that patients don't always talk about death a lot when they're near death. I find they talk about life.
Hmm.
They talk about their children, their grandchildren. They talk about everyday things. That's what becomes important to them. They talk about what is that made their life. They don't talk about death necessarily. I find and what they talk about is what I have learned is that is what's most important to them. Talking about their grandchildren or their garden or what they did. It isn't, and that's number one. Number two is they don't think like me. So I'm a nurse, you're a nurse. I walk into the home, hearing, knowing the last report, they have a cancer that's been causing pain, or they have congestive heart failure, or all these other things. We don't, people think that all our patients have cancer, and that's far from the norm. They have congestive heart failure, and I'm worried about how is their breathing, how are their lungs, are they going to fill up with fluid? What am I going to do about it? Do I have Lasix in the house? I'm on that page, and they're on totally different. And that's been, I still work very hard at trying to listen to what they want to talk about and then because we think upstream. So that's part of my job. I need to, because I'm leaving that house and may not be back again for a few days, even though they have on call. I got to figure out what may happen and plan for that. So, but they don't really care about that. Sometimes I scare them when I talk about those things. So that's like a separate piece. My social worker said it the best. She said, Mary, we're both reading a book. They're at the beginning, maybe the middle. We're at the end. We know how this is going to happen. And we're thinking about that and how we can prevent a bad ending. And they're on a total. So I try and remind myself of that. Well, those are two things I've learned. What else? What was your question? What is the third thing I've learned about dying? I find people, they avoid it. And I do ask them generally, are they anxious? I try and, I'm very careful of use of the word die because I think it does scare people. And that may sound like sometimes I feel like I'm not really doing my job because maybe I should talk about it. But I find a lot of people want to talk about it. So I'll often say, I'll just say, are you nervous about anything? And some people will then reply, yes, they're nervous about dying. And then I'll say, what are you nervous about? And generally, and I think you said this in your podcast, they're nervous about they'll die in pain or another symptom. And so I usually address that because I usually feel we can address the symptoms quite well. But I'll ask about other things, the spiritual, the psychological, the fears. What else are you worried about? I'll be honest, I don't always feel that I'm the best person suited to help them. But if I can identify that I can get another member of my team in there to help them with that. So, but I'll often find they don't open up for me. I've been, because I'm spiritual, I'll often say, are you a spiritual person? And they'll say, I'm shocked at how many people say they're not.
Really?
And if they are spiritual, I'll say, do you want to share your beliefs? Do you want to talk about them? Are those the source of your anxiety? And someone will say yes, or someone will say no, I believe in life after death. And then I feel very comfortable talking about that, only because that is my belief, and I'll tell them that. And I find, I'll ask them, do you find comforting to you? And the people who do find comfort in that, they'll talk about, they look forward to seeing their loved ones there. So we talk about that. So I feel comfortable about that. I feel always, though, your question is a good one because I often think there's something else there, but I'm not the best person to do it.
Well, I can remember when I would take students into, in hospice, when they would go, into hospice as part of their clinical rotation. And they would be looking for that hospice moment, helping, the angels are singing and there's a halo over the dying person's head. And, there's this fantasy about what, the holiness of that hospice moment. And they get to the house, and I can remember one woman had all these wallpaper books all over her house. And she's like, I need to pick out wallpaper for my kitchen. You want to look at some? And we sat there and looked at wallpaper samples because that's what she wanted to do. And you go to another house, it's like, well, I want to do this. I want to take this trip to, where did that one woman want to go? The Bahamas or somewhere, and had to figure out, well, how do we get, back then the cartridges for the pump and all of that? How do we get that so that she can go to the Bahamas? And the students would always be like, this isn't what I was thinking hospice was going to be, because hospice is about life. It's really not about dying, right?
I agree. It probably is for the family because you're worried about losing the person. But I wish I knew more about dying, and I wish people talk more, but I don't find that they do. And I don't know if that's because they're Americans or they're afraid, or we talk about what we know, and we really don't know what dying's going to bring, so we talk about what we know. Right. I love the wallpaper thing, though. That's great. And what is the meaning of that? Who knows?
Or I don't know, maybe there isn't any meaning at all. She's just sick of the wallpaper in the kitchen, and now she's got other women coming in who can look at the books with her. I don't.
But I think one of my bosses will always say, if it brings joy to people,
right?
That's what we do. Yeah. that's what's important to them. So, yeah.
So has doing this job for 30 years changed anything about how you live your life?
Oh, absolutely. Absolutely. It makes me focus on what's really important. You try and not sweat the small stuff. Doesn't mean you don't sweat it, but I really try, and I have an intolerance for when other people get so upset about the dent in the new car, or, this is what's important. Like, life and having each other, and you never know when it's going to be taken away. And so relationships are important. Health is important. And loving one another is so important. And listening to what other people think is important. It's not about me,
Well, it's about
even
you.
though I talk a lot.
It is about you in terms of how you change your life or how you view your own life, right? If you take these visits with people who are terminally ill and listen to what they're concerned about or what their issue is or what they want to talk about, and then how it affects you or if it affects you in the choices that you make. I don't know. Do you have
It
one?
just,
Oh, go ahead.
no, go on. No, yeah, it just it makes me see what's most important in life. And you do value. The other thing is, I feel more comfortable with death and dying and talking about illness. It's what we're all going to face. And so many other people have such difficulty dealing with it and talking about it. And I feel bad for them because, it's, even though it's difficult, it's so important and so meaningful when you do take the time to talk.
Well, that's one of the reasons that we started this educational endeavor and called it Everyone Dies is because let's just it's sort of like, let's face the facts. It's not an option. There's not a lot about it that you control. You can say, well, I'm going to fight this illness, but that's no guarantee. You've worked on oncology, I've worked on oncology. People always assume it's the cancer that's going to be the thing that ends their life, and they're very surprised when it's something else.
Yes,
and
yes.
and so it's like, yeah, you've spent all this time focusing on the cancer, but little did you know that your pulmonary hypertension or something else
Exactly.
is going to be your problem, or the
And
thing.
people get angry. People get angry and frustrated.
What do they get angry
We
and
think we
frustrated?
know the body, and
Oh,
the body is complex.
yeah, there's lots of stuff that goes on that we think that we have control over, but we absolutely really do not. And so the thing that you do control is your attitude, right? And
Hmm.
you know making the best choices you can with the information and the resources you have. And beyond that, the universe really is in charge, I think.
Absolutely. Yeah, absolutely.
Do you have one patient that you've had in hospice that you'll never forget?
Yes, yes. It
Can you
was,
talk about
yeah,
it?
sure. It was a man who, I believe he had lung cancer, very ill, and was debilitated too. I want to say he was an amputee or something. Very ill, and it was early in my hospice years, and I would knock at the door, and he would very jovially yell out, "I'll be there in a minute! I'll be there in a minute!" And he would put his leg on, and he would come to the door and let me in. And he's just the happiest, go lucky person. And I'd say, "How are you?" And he'd say, "I have lung cancer, I got heart failure, I got this, and I got the best wife in the world, and I don't have a thing." and he meant it. He was very authentic, and it was just so inspiring, so inspiring.
Wow.
So
What do you think you learned from him? What do you carry about him within yourself?
that to focus on certain things, thinking they're going to be the end all be all of your life, like you said. You have a lung cancer, maybe it'll kill you, but maybe you'll get hit by a car tonight, or maybe your child will get hit by a car tonight, and who cares about that?
Mm-hmm.
It is, and just it, and being grateful for every day you have. I mean, he was older, and I'm not saying, sometimes I'm finding people, the older they live, don't want to die. And their expectation is, I'm not ready to go yet. And no one's ready.
Mm-hmm.
But you've had this long life, and other people haven't. So he taught me to really focus on what is good around you. And really, who knows what's going to take you down, or be, and he was very grateful for his wife. There's some people that never have a good marriage, ever. Um, so, and that can kill you emotionally for years. I mean, you can live in sorrow and depression for years. So what's the difference? What's the difference of dying? I'm not I don't ever mean to minimize death. It's a very sad thing, but I don't. I also have my belief, my faith. I believe in God, and I'm Catholic, and I believe that there's a life after.
Mm-hmm.
So I feel very comfortable that, even though I'm scared of death, but there's something after. Um, that's what it taught me, to recognize what we have in life and what gets you through. Because I see people all around me that have their health, but I don't think they're happy.
Mm-hmm. Or they're, as my mother would say, fritting it away. It's like they're not making the best of it. They're not
Right.
doing exactly. And living and seeing, and I don't know.
Yeah.
Making the most of it.
Life is, yeah. So that's a sad way to live.
Yeah. At least I think so. And they don't seem all that happy either. It's not like they say, "Oh, I lay on this couch all day and I'm thrilled." It's
Right. Right.
probably more depression that's maybe never been treated. I don't know.
And there's also other populations that live in poverty and, lack of education, and I don't know what their lives are like, so I really, I love it when someone, whether they have a medical illness or not, looks at the big picture and says, I'm happy for what I have.
Mm-hmm.
And I do see a lot of people like that in hospice. I think, and I'll just add one more thing. I think, because I do palliative care consults now, and I think the big difference is that in palliative care, a lot of the folks are still fighting this disease. I think that takes so much energy out of them.
Oh,
and
yeah.
if they're not gonna, if they're gonna eventually succumb to it, I often see when they go into hospice, there's like this sense of relief. They don't have to fight anymore, and they can kind of smell the roses.
Mm-hmm.
And take the time to appreciate what we do have. And again, I'm not minimizing their loss or their pain. I don't mean to say it rightly, but they just seem happier that they can, have visitors and they're not worried about tomorrow's chemo, which may or may not work.
Well, and that's the thing with the chronic illness, is that it really becomes a full-time job for people, because if you're not going in for chemo, you're going in for lab draws, or you're going in to see one specialist or another, or you're going in for your palliative care appointment, or you have an MRI or CT, and it's just a full-time job that you have no energy left to say, I'm going to go work in the garden today because either you don't have time or you don't have the energy. And it's like, sometimes that's just such a hell of a way to live if you're on your third or fourth type of chemo.
Mm-hmm.
Your chances of um, that chemo working, when you're on fourth line, is pretty nil. But yet you say, nope, give me everything you got. It's like, everything you got, geez, this chemo can result in the end of your life.
Mm-hmm. And if that's what they want, okay. But if it is a full-time job. And the other piece is, I'm not saying that some of the physician visits are appropriate, but I mean, do you really have to go to everybody? Do you have to go to the PCP? And, because then they come back with this false sense of assurance that everything's okay. Well, what does that mean? It means your platelets are okay today. What does that mean? I don't know. It again, if that's the way they want to spend their last years, go for it. But it's not the way I don't think I'd want.
And there's even data showing where they've looked at people who've had, the full court press treatment versus those with just palliative care. And the people with the palliative care can survive longer and have a better quality of life.
Exactly.
So,
are you talking about Temmel's study there?
Where there's Temmel's study, there's studies on palliative chemotherapy, which looks at, it's like, oh, we're gonna manage the symptoms with chemotherapy, when in fact the quality of life is far worse than if you manage the symptoms with medications rather than with chemo. Kind of really informing yourself about what is your goal of care and what are you willing to do, and to really ask the hard questions of, what is this going to give me? Is this going to give me one more day? Is this going to give me one more week, one more month, or one more year? And I've had discussions, where a patient needed a certain mobility wheelchair or something, and their thing was, these things cost, I don't know, $6,000. So insurance wasn't going to approve it if they only had 6 months left to live. Because it's allocation of resources in certain systems. And it's like, you'd optimistically like to say, yeah, they'll be here for 5 years. But then there's, Joey and Lynn's surprise question. Would you be surprised if they were dead in 6 months? Well, no, I wouldn't be surprised. There's certain things that are going on, and it wouldn't surprise me. And so, and kind of having that discussion and letting people ask questions and giving them honest answers. Because patients will say, I've asked my doctor and they won't really give me a straight answer.
Right.
How many times have you heard that? They want to know yes or no. It's like, well, okay, let's talk about, because, we do evidence-based practice. Let's talk about, what does the literature tell us? What is, your particular case against that literature? Here's what, we can guess. And I always tell them, we're guessing, because, I don't get any memos from God that this is what the fact is. But based on what we know in science, here's what we can assume is going to happen. And they'll be like, thank you. Thank you for just explaining that. That doesn't necessarily mean they're going to do anything different, but at least that gives them one more piece of information when it comes to making, decisions for themselves.
And uncertainty, I think that's what you're speaking to, uncertainty. It's always uncertainty in medicine, and I think people need to hear that.
Glenn, she's being taped.
And there's always uncertainty. And so people need to hear that. I think they think there's a magical, definite number out there. I like to say to patients, how do you want to spend the rest of your time?
Mm-hmm.
Whatever that time is, how do you want to spend that? And I think that helps. Well, it helps me to get to know how oftentimes they kind of look at it.
Mm-hmm.
And the whole piece about function. I think what I've learned is, there are prognostications, but it comes down to function. If you're not getting out of bed and you're not eating, you're going to die soon, and I mean, if that goes on.
Mm-hmm.
I don't care if chemo's supposed to keep you alive for another 6 months. So you really got to look at these about that too.
Yeah, I remember having that conversation when I worked in hospice in New Hampshire, and there was snow on the ground, and I was talking to the patient, and he said, "Well, am I going to live long enough to plant my garden?" And I said, "Well, there's snow on the ground now. We probably don't have spring for another 3 months. So if it's your goal to be able to go out there and work that dirt, you're going to have to get up from your chair, walk around, work with PT, keep your muscles going, and, mind your nutrition." Because this was somebody who wouldn't get out of his chair. He just wanted to sit in his chair. Said, it's really up to you, because in order for you to go out there and dig in the dirt, you're going to have to be able to walk. So you have to maintain your ability to do that. And that part's up to you, because it wasn't his disease that was keeping him sitting in the chair. So there's choices. Okay. There's choices we make. And sometimes, the body starts to shut down, and you just don't want to.
Indeed, he can do that.
Right.
Yeah.
Right.
That's hard for people to understand.
Right.
I don't understand. They don't understand, or I think we need to do this better job in 8th grade. Organ failure, what that does. It comes down to that, and I don't know. And people have a hard time understanding that.
No, there's a lot that I think isn't understood about our bodies. And as a gerontologist myself, it's like when you're 50, it's a little late to be worried about, your health and your function on certain levels. It's like you really need to start pretty young in terms of your nutrition and your exercise patterns, and whether or not you smoke, and whether or not you drink and drive, and those other things that impact if you're going to get old and how healthy you are going to be when you do get old. Like you can't wait till you're our age and suddenly say, "Oh, well, now I'm going to start jogging." I mean, you can maybe walk pretty fast, but I'm not sure about, fast jogging. But maybe some people can start at 60, but I sure in heck can't.
No. Yep.
So what are you most grateful about in terms of having worked as a hospice nurse all this time?
Well, I have I've learned a lot about illness, also serious illness, other serious illnesses like pulmonary fibrosis. What I've learned from the patient, but I think I've already said that. Second, again, about the illnesses and how they affect the body, and about medication management and other strategies to help with symptom management. I've learned a lot. I've learned a lot about medicine too, the limits of medicine.
Well, I appreciate you taking the time to talk with me, and I hope you'd be willing to come back and have another chat about other things in the future.
Okay.
I love talking to you. And thank you for listening. Please stay tuned for future episodes of Everyone Dies. Our thanks to our executive producer, David, our producer, Sandy, John, our technical advisor, Molly, our Twitter correspondent, and our friends and family and our loyal listeners who are supporting our work at Everyone Dies. This is Mary Ann Matzo, and we look forward to talking with you soon.
Remember, every day is a gift.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.